Next on Primary Care, Alzheimer's and Dementia, understanding the power of an early diagnosis for better care and treatment.
The earlier you get diagnosed and the earlier you take care of things, there are some things we can do to help slow down that process. And then if we wait too late, then it's almost impossible to really treat those patients.
Hello, and welcome to Primary Care, the show dedicated to improving the health of African Americans. Did you know that most Alzheimer's and dementia patients, especially in the Black community, are unaware of their diagnosis? Many patients and family mistake early symptoms for normal aging or avoid testing due to fear and stigma. The caregivers, who are often unfamiliar with the disease, may not recognize the warning signs. According to a University of Michigan study, even physicians face challenges, and especially in the current practice setting where time constraints and lack of specialized training can delay the diagnosis. Here with us today to discuss the importance of getting assessed properly for an early diagnosis is Dr. Stephen Hardy. Dr. Hardy is a neurologist at Oakland Neurology Center specializing in adult neurologic diseases. Dr. Hardy, welcome to the show. Thank you for coming, second generation. We appreciate you.
Thank you.
Dr. Hardy, why is it so important for African Americans to get evaluated and tested for early Alzheimer's and any form of dementia?
Well, I think it's especially important because, the deficits that we see if people don't do that. Mm-hmm. So with degenerative conditions, especially in neurology, the earlier you get diagnosed and the earlier you take care of things, there are some things we can do to help slow down that process. And then if we wait too late, then it's almost impossible to really treat those patients. So I think it's very important to look at things early, know the signs, and get things treated.
Right. It's sort of like the horse is out of the barn, not just out of the barn on this disease state, but it's the horse is out of the barn in the next county in another pasture, and then we try to treat these patients, which is like, saying, boy, we lost the real opportunity up front to start talking about early diagnosis and early treatment, and therefore a better outcome.
Correct, yes. You want to catch them, right at the beginning of that process, because if you wait too late, it's definitely going to be a problem.
So what are the stages of this disease that we have to deal with almost on a daily basis?
So simply putting, we always talk about mild, moderate, and severe. Mm-hmm. In certain research trials, they use some different criteria, but clinically speaking, we use mild, moderate, and severe. So on the mild aspect of things, we always deal with memory loss and, how it's starting to impact their ability to function daily. And then when we get into the moderate phase, it becomes probably obvious to other people, even observing these patients. And then when we get into the severe category, this is when we're talking about patients who have difficulty with their motor function, their bowel bladder habits, and just their ability to function independently, and then they depend on others to do all of those functions.
What tests do we have at our disposal in terms of actually making an assessment and classifying these patients?
So a lot of new things have come out recently, but just to kind of go back historically, just a clinical test, so your history and physical, basically. So we have what's called a mini mental status examination, right, or a Montreal cognitive assessment. These are standardized tools that we use in the office setting just to test different parts of the brain, whether it's executive functioning, your short-term memory, language function. So it's a 30-point test that we use to score, just to screen patients and see what their cognitive abilities are. And then outside of that, we also have imaging modalities where people use MRIs to see, well, is there something secondarily causing things, or is there some primary degeneration in those memory areas? And a lot of new things out, not to get too carried away, but there's some blood testing now. Mm-hmm. There's cerebrospinal fluid testing we can do to look for markers of Alzheimer's specifically. And even more recently and more readily available to the clinician, we have PET scans that look at markers specifically towards Alzheimer's to see if it's present or not.
Mm-hmm. We're always surprised in the office and the outcomes of different patients. You've been seeing them over and over again, and all of a sudden, boy, it's time for us to do a memory assessment on this patient according to the calendar of what they haven't had in the past. I'm just amazed sometimes at the patients that pop up that you just would not suspect that they couldn't remember 3 words and recall them, or could not distinguish between a quarter and a nickel, you know, in a bag, or could not draw the time on the clock. I mean, are those still valuable tools? Are those kind of approaches still valuable tools? Because it slips us on us in primary care sometimes.
Yeah, those are still very valuable, and actually some of those are included in some of those cognitive assessments I mentioned. So when you're just talking to someone casually,
They can fool you.
times, yes, they can definitely fool you. But when you get deep into the minutia of actual questions like those modalities you mentioned, you can start to tease out some of these abnormalities, which is sometimes difficult in that very mild phase.
So what kind of different dementias are there? I mean, we're all, you know, the community is well aware of the Alzheimer's, but what about the vascular and Lewy body and the other types of dementias? Tell us a little bit about those.
Yeah, so there's a few different types actually. So the second most common, second/third most common is probably vascular dementia. That type of dementia, instead of a progressive decline we see with an Alzheimer's type dementia, usually more of a stepwise decline where you have some sort of vascular insult, whether it be a stroke or a silent stroke that you don't even know you're having, and then you start to notice that kind of decline stepwise. There's also Lewy body dementia you mentioned, where usually within the same year, people start to develop some cognitive slowing. They start to exhibit some Parkinson's type symptoms where, you know, you're shuffling your feet when you're walking, you're talking and moving slower, and you can develop some tremors, especially in the resting position, along with the progressive memory loss. And usually those patients have some fluctuations of hallucinations, agitation periodically that can clue you in as well. There's also another big one called frontal temporal dementia as well. That we don't see as much. There's some subsets of that. I think most famously, people heard about Bruce Willis, and you can present what we call a primary progressive aphasia, which is more just a language dysfunction. But that's a subset. Frontal temporal dementia, you can have language dysfunction primarily, more so than memory, and then a lot of behavioral abnormalities. So people saying inappropriate things, doing inappropriate things, just bizarre behavior is the hallmark of that disease process.
So in the primary care setting, we see patients who have been taken to the emergency room for some type of mental status change. Mom had a little bit of slurred speech or whatever. The workup is totally negative in the emergency room, and they're classified as transient ischemic attacks or TIAs. How does that play into what we can suspect in terms of possible underlying dementia?
So when we have those types of risk factors, especially vascular ones, when someone comes in with TIA or multiple times of that, and then we do testing and don't find anything concretely, those other types of comorbidities can play a role because, you know, those blood vessels are feeding the brain, and if they're constantly under attack, if you will, it can definitely lead to further cognitive changes down the road.
So why are African Americans seem to suffer from this disease at an alarming rate compared to other populations?
So there's a few different things. You know, I think access is one. You know, unfortunately, historically, we're mostly in underrepresented communities to healthcare, and just having the access to someone to screen for those things is one part of it. Education is another. Just knowing what the signs are. You know, like you mentioned, people say, "Oh, that's just grandma, that's just grandpa being himself." But actually, there is something going on, and just noticing those signs is very important. And then other risk factors for developing dementia in general, just other medical conditions. So, you know, high blood pressure, you know, elevated cholesterol, you know, smokers, all these things, excessive alcohol use, sleep apnea that's untreated. So these are a lot of things we screen for in people with some initial memory problems. But knowing those things is definitely beneficial. But, you know, if we're not treating them or going to see the doctor because we have that lack of access, I think all of those things help, you know, with that problem.
So we still see this fear in every community to be labeled with this disease. There are so many ramifications with it. How the rest of the family feels about who's going to be responsible for the patient. Are there any financial issues? Are there any larger issues that would relate to the family as a whole? This has far-reaching effects in terms of, as we initially say, somebody is suffering from some form of dementia. And we understand that that labeling can be very important in terms of the outcome for these patients also, especially in terms of what kind of care they get down the road, and also who provides that care. A lot of times we are relying on a family member, mostly of some sort, to be responsible for the needs of that patient. How much of a barrier is this in your practice?
I think in terms of, the family member taking over as the primary caretaker, I think in my practice, most people are pretty overwhelmed by that task, and this the stigma of having to do that. So, with dementia, it affects the patient and the caretaker. So, this lack of resource, when people try to assume that just by themselves, can be overwhelming, and then it usually leads to a unsettling or unsteady household. So getting on top of these things early definitely would be beneficial. And then, there are other resources out there. I always revert people to the Alzheimer's Association.
Sure.
They have typically in certain areas and counties, they'll have some different group sessions where someone's going through the same thing as you. You can talk to them and figure out what the best game plan is. Because as a clinician, I can do the medical part and try to be there, but I'm not there for the day-to-day activities. So having those resources or caretakers that can come in and alleviate some of that burden is very important.
So the social service aspect plays a huge part, not only in just the care of these patients, but also in how well these patients do overall in terms of dealing with this disease. Is there a difference in the penetration of this disease between men and women?
So the difference would be more in terms of like risk factors, right? So historically speaking, men were suffering from high blood pressure. They were smoking all the time.
Didn't see the doctor.
Didn't see the doctor because that's not a manly thing to do. So their penetration would be a bit higher. Now, as things have changed, women are more in the workforce, professional, and on an equal level, we're starting to see a little bit more penetrance in terms of somewhat equal, but the main risk factor is life expectancy. So the person who's living the longest is going to be at the highest risk to get the disease. So now, with men, even though they have those risk factors of having it happen, now that the population of the U.S. is getting older, women are outlasting men, so they may be more prone to getting the disease themselves just by chance of living longer.
So the presentation needs to be taken, or it needs to be taken into consideration at the same time about who you're actually treating and suspecting the problem in. And we haven't not necessarily done that. We take the science and we think everybody fits the science. And in actuality, we need to be looking at these diseases sometimes from a different perspective. How many doctors will arrive at the place that you just did by stating that, men live less, therefore, that's not a common approach with men. We're just glad to see them show up at the office for anything because they haven't been there in a while, okay? But here again, there are a lot of things that drive those factors, but here again, the point that you make about people living longer that eventually will develop disease is very important. That leads back into something we discussed earlier in terms of early diagnosis. Is there a point that we're at now where we can rely on some technology? Like you did mention blood tests. We also have the buccal swabs for genetic testing and stuff that we do now that give us some indication that there might be an underlying problem with this patient in terms of dementia. Is there anything else out here in the Star Wars arena? You mentioned PET scans and stuff. Is there anything else that we could be saying, boy, you need to go straight to this test to see where you're at this point in time?
Yeah, so once we learn those risk factors, once we learn those early signs, anything that's different in terms of memory loss or behavior, getting to see the neurologist, we can do one, the assessment in the office, but two, there's a blood test. So with Alzheimer's disease, right now, historically speaking, Alzheimer's disease is caused by accumulation of these abnormal proteins in the brain and the memory areas called amyloid, right? And then there's some tau proteins that are involved as well, and they form cell disruption that go towards the disease. Now, there's a blood test available now where we can actually look for, is the amyloid there and it has a high level? Is the tau protein there? Is it at a high level? Even though you may not even have severe symptoms. And then that can clue us in early that we may need to go towards a treatment and slow the process down a bit sooner. And then linked into that, we can have the PET scan, which is a picture of the brain that looks for the amyloid presentation. And putting all those together at a very early stage, there are medications available now within the last 1 to 2 years that target the amyloid, clear it out the system, and slow down the progression of the disease. And the earlier, the better, because it's actually only indicated for people who are almost dementia, mild cognitive impairment we call it, or very mild stages. So very important to get in early for that.
Do you run into any barriers actually getting patients in line to get to these sophisticated tests? I mean, are we being denied by insurance companies for a blood test of this nature, or a PET scan to actually get some real diagnostic criteria?
So 1 year ago, yes, we had a lot of barriers getting that done. Within the last 6 months especially, it's becoming more common practice, and I've even seen primary care physicians checking for this as well. But the blood test is pretty readily available. The only issue that we run into with insurance in terms of treatment options, they don't recognize it for them to approve the treatments. So that's why we have to go in to get the PET scans or a spinal tap. But the PET scan, up until January 1st of this year, was a big issue getting done because no one wants to have a spinal tap if they can avoid it.
Right.
So getting a PET scan is much easier because of some things that have changed with reimbursement for the people doing the test. So I think right now it's a very exciting time because these things are becoming more readily available.
Do you see any other barriers in terms of, you mentioned primary care physicians beginning to buy into some of this testing. Do you see any real barriers for us in the primary care space to actually shy away from being more proactive with ordering these things? I mean, University of Michigan study showed that time constraints alone can delay a lot of this type of activity, especially in this disease state. What should primary care physicians be doing that can actually step their game up to support the diagnosis of this disease, especially early diagnosis of this disease in patients?
And I think one of those barriers is time, right? Because you only have so much time within a visit. But doing those annual memory screens, the cognitive assessments is very key. And if that's abnormal or something's off, sending them to the neurologist to get that treatment early. And then not being afraid just to order something, order the MRI, order the blood tests, because the earlier we can get that done, and then by the time they see the specialist, we're not ordering it and then waiting again for those to come back. So I would highly encourage the primary care physicians, allowing the time to be there to get those things done, all in support of getting that early diagnosis.
Okay. What about a family history in terms of this disease? My great-grandfather on my mother's side had this problem. I mean, do we really see penetration in terms of this disease affecting people?
Yes, so there is a genetic component. They've isolated a number of different genes that that have been, in concert with the disease. Now, one specifically with the blood test I talked about, there's a gene called apolipoprotein.
Right.
So we can, when we're doing blood tests, we can actually screen for that and look at the different, makeup or composition of that genetic and see if there's a higher risk going forward. Now, the other ones, the genetic testing, we don't really screen. One, they're probably too expensive at this point, and then two, it's sometimes just screening for that may change the way someone lives, so we try to shy away from that a bit as well.
Everybody is on a exercise and weight loss craze in this country. Does diet and exercise play a role in the treatment or prevention of dementia?
Yes, so we always talk about, primary prevention, right? So good diet, good exercise is definitely beneficial for these patients, and one, preventing, and then two, if you are diagnosed, it can help slow down that process. So with my patients, I always encourage three different things. You always want to stay physically active. You always want to get the blood pumping to the brain, getting the oxygen so it can function as best as it can. You want to stay socially active because human beings are social creatures. That'll kind of keep the brain just active in its day-to-day routine. And then do intellectually stimulating activities, whether it's a crossword puzzle or they have these apps called brain games or whatever it may be, just to keep the brain active for sure. And then especially healthy lifestyle and diet early just to prevent, because speaking of the genetics of everything, there may be something in the environment. You may have the genetic predisposition, something in the environment, all the high blood pressure and something you're exposed to may actually turn it on and make it happen quicker than normal.
Alcohol, any role?
Yeah, definitely a big risk factor. So large consumptions of alcohol I've seen trigger dementia in general, alcohol-induced dementia in very young people. So alcohol has a deleterious effect to the brain where it actually causes the brain to shrink out of proportion to just the normal aging. And then that out of proportion shrinking leads to actual deficits in the memory areas, and these people can't function, and then they're 50, 60 years old and can't care for themselves. So alcohol, excessive amounts, definitely can be a risk factor for that.
Okay. Is it me, but we seem to be seeing a shift in terms of presentation in age groups. We talked about this a little bit earlier, that the people being told that they have early dementia of any sort, the age group seems to be shifting down. Is that related to all the other risk factors, or lack of treatment of those risk factors, or alcohol? Are there any other reasons that this is happening, or is this the natural progression of the disease?
I think, well, one, there's more awareness, and then people are getting diagnosed at a point
Earlier?
where they wouldn't,
Okay.
they wouldn't really have done so previously. But I do think it's the way America's living these days, and a lifestyle where, we're not in the same shape we were when we were, walking to work and doing all these activities every day. More sedentary lifestyles, like we talked before about risk factors of developing. I think that becoming more prevalent, unfortunately, is a reason why people are actually being diagnosed earlier, especially if they have that genetic predisposition.
Mm-hmm. So we now know more about this disease state than ever before. We have a new term that's been applied to dementia, type 3 diabetes, looking at all of the data that has come out about abnormal glucose metabolism in the brain associated with the development of plaques and tangles, and all of that scientific research stuff is coming along. And also, in the last couple of years, there seemed to be the approval, at least by the FDA, of 2 new medications that are intravenous for this disease state, which is almost impossible to get at this stage in the process. Have you seen anything that gives us any hope along the lines in terms of those medications? I ask that because we can't be satisfied with what we have had to use over the last few decades to treat this disease. It just has not stepped up to the point that we can put a lot of hope in it like we do in other disease states. We get the blood pressure down, we get the A1C down. We just haven't seen that kind of response in dementia.
Yeah, I think speaking of those medications specifically, they are becoming a bit more readily available to get done. I think there's a lot of excitement behind it. I mean, there's some risks and benefits that I always discuss with the patients in terms of what to monitor during that. I think it's not to get ahead of myself, but I think those are very exciting because when we talk about can we cure dementia, so those abnormal proteins I talked about, the amyloid, the tau, they take 10 to 20 years to accumulate yes. before you even show a sign of memory issue. So if we could screen like diabetes or screen like something else with a blood test before you have actual symptoms, could we introduce those new therapies you mentioned to clear out the abnormality and not even develop the disease? So in terms of excitement around those 2 new therapies, I think, yes, very exciting, but extrapolating that to what can we do in the future to actually really cure Alzheimer's. Time will tell. Targeting other proteins, I think there's going to be a lot of excitement in terms of the treatment of Alzheimer's in the next 10 years.
This is a church community. Do you see a role for the church, the faith-based community, in terms of treating these patients?
Yeah, I think they've played a large role historically in the African American population, just in terms of getting information out, right? So if people are attending church, but not necessarily your doctor, so how can we inform these people about what's going on? So having you or I go into their church facilities and just talking about different topics will be one thing, but just having your pastor or your preacher sit down with you, talking to you about things, or even just in the congregation itself, just to have education and information about what is going on about certain disease states, I think that's very important. So I would highly encourage them to play a large role in getting the information out. And then also you talk about, the caretaker and the burden one can have with caring for the dementia patient. That's an outreach that you can go to for support as well, just in terms of the totality of the disease.
Right. One of the worst things that I've seen happen as a practicing physician is when the caregiver gets sick and can't provide the care, and you're stuck with a patient who now has to have a decision made on where they go and everything else associated with activities of daily living, lifestyle, everything else, it can be a royal disaster in terms of continuing to take care of your patient after that caregiver has gotten sick or unfortunately passed. This has got to be a nightmare for you too, especially in this disease state.
Yeah, very difficult. So when these because the caretakers are the ones that are bringing them to the office to get evaluated,
Exactly.
right? So if that person is not there anymore or physically incapable of doing that, they're lost to follow-up because some of the services at certain facilities they may be transferred to, yes, it's great if they can bring them, but a lot of times that's not the case, or it's just they can't afford to have that service added on to where they're living. So unfortunately, they do get lost to follow-up sometimes and can't have or even talk about these new things that we're talking about in terms of treatment. So very, very frustrating.
Yeah, it can be a real eye-opener to go from having sophisticated treatment to losing a patient because of simple social services not being available. Steve, this has been an exciting discussion, and as I get older, I am even more and more interested in this whole disease state. Thank you so much for joining us. We appreciate it. We'll do it again.
Thank you.
Okay.
Thank you for having me.
We've been speaking with Dr. Stephen Hardy, a neurologist at Oakland Neurology Center. Remember, an official diagnosis of Alzheimer's or dementia can only be made by a qualified healthcare provider, like your doctor or a specialist. The sooner you or your loved one gets diagnosed, the sooner you can access the right care, resources, and support to help manage this disease. For Primary Care, I'm Dr. Lonnie Joe.